started. It's a great pleasure to be with you all today. Thank you very much for the invitation. I was asked to talk about pre-hospital transfusion with blood. Because I was in the military for so long, I like having outlines, so we'll talk history, epidemiology, which comes from a trauma registry and a trauma system. We'll go through blood ratios versus crystalloid, blood components versus whole blood, when to give the blood, and what product to give. You all know this better than I do, but last year on July 11th, the Minister of Health of your country put out a decree that made it legal to give pre-hospital whole blood and in-hospital whole blood, plus many other interventions that have come from the joint trauma system in the last 20 years of war in Iraq and Afghanistan. I've had the opportunity to serve in the U.S. military for 23 years and have been deployed in multiple combat zones around the world. And I was fortunate as a civilian to come to Ukraine 3 times last year and participate in the care of patients. Albeit not in the East, I stayed more in the West. I'm looking forward to coming back to Ukraine again. If we look at the evolution of resuscitation blood resuscitation was the primary resuscitative fluid for 127 of the last 159 years. So about 30 years where we got a little distracted with crystalloid, but have come back in the last 20 years to more blood product resuscitation. History is important. We must learn from history and understand what was done. In World War II, hundreds of thousands of units of whole blood were given. And they were given pre-hospital on the beaches and in the dirt, in urban warfare by medics, not by doctors, not by nurses, but by medics, gave whole blood to combat casualties very soon after injury. In Vietnam, the U.S. forces during that 20-year war started giving lots of crystalloid, and this is when ARDS was first documented. So the relationship between crystalloid and ARDS, pulmonary injury, and edema really starts in the Vietnam War. My first deployment, taking care of combat casualties, was in 1993 in Somalia, in the Black Hawk Down incident. It's when I first gave whole blood to combat casualties and was very impressed, a long time ago, how well it worked in the casualty care of those significantly injured patients. We then moved forward to Iraq, and in 2007 we published a paper that looked at the cause of death of combat casualties. And you all know this already, but for us it was useful to publish these data, that in our conclusion from this paper focused on special operations soldiers who died, was that improved methods of truncal hemorrhage control and resuscitation with blood products had the greatest potential to improve outcome on the battlefield. Moving forward to Brian Eastridge's paper, this is a really important paper that covered 10 years of war. And you can see that the majority of the deaths that occurred on the battlefield in soldiers was pre-hospital, again, something you all know very well. But the leading cause of death was far and away hemorrhage. And so focusing our efforts on hemorrhage control and blood resuscitation is a very data-driven program of effort. Now, in 2006, I was deployed to Baghdad, Iraq, and was caring for combat casualties. And in between operations, wrote this editorial called Damage Control Resuscitation. And the focus of damage control resuscitation is on that 10 to 20% of casualties who are really seriously injured. Most casualties, frankly, have relatively minor injuries, but the group that are seriously injured obviously have all of the death. And so we need to treat those patients differently, and came up with this concept of damage control resuscitation. What is damage control resuscitation? Well, number one is stopping bleeding. Number two is hypotensive resuscitation. Don't raise the blood pressure too high because that increases bleeding. Minimize resuscitation with equal ratios of plasma, platelets, and red blood cells, or whole blood, which of course is easier to do than 1:1:1. Using plasma as a primary resuscitation fluid, increased use of platelets, giving platelets early, while reversing hypothermia and acidosis, and utilizing all hemostatic adjuncts to improve the outcome of the patients. By doing this, what we documented in 252 massive transfusion patients is the patients who had damage control resuscitation had a much better survival than the patients who had an unbalanced resuscitation. Now, subsequent to this, there have been many military papers published on using whole blood or balanced resuscitation, and literally hundreds of papers from the civilian world, all over the world, not just the United States, but in Europe and other places around the world. When we came back out of into the civilian world and into the United States, we looked at 16 centers, trauma centers in the United States, and asked if we were seeing the same thing in civilian trauma patients, not combat casualties. And what we found, and I'm going to go through this pretty quickly, but this group that had balanced resuscitation with plasma, platelets, and red cells did far and away better than the groups that were unbalanced resuscitation. This is important because this is a paper that looked at giving plasma and platelets, and the group that got increased plasma and platelets did the best. You will hear this over and over. It's not just one, it's not red cells, it's not just plasma, it's not just platelets, but it's all of them together. And then we published in JAMA in 2015 a prospective randomized study looking at the ratios, whether the ratio should be 1:1:1 or 1:1:2 of plasma, platelets, and red cells. And we showed that by using a more balanced resuscitation that approached whole blood, we decreased exsanguination significantly with the first 24 hours. Now, 2 slides on crystalloid. I personally think crystalloid is really bad for patients. I give no crystalloid when I take care of trauma patients today that are seriously injured. And when we looked at the data out of that prospective randomized study, every 500 milliliter increase in crystalloid during the first 6 hours was associated with a dramatic increase in ARDS. Blood products were not a risk factor for lung injury. This is very different than what I was taught as a young surgery resident or as a critical care intensivist, and what I taught people for a long time. But these are the data. Blood products are not pro-inflammatory, and crystalloid is. Crystalloid increases ARDS. So we came up with a new term called crystalloid-related acute lung injury. Brian Cotton published in 2006 a really good paper that looked at crystalloid use throughout the last 30 years. There's not a single paper that I can find that says giving more crystalloid is better for your patient. Every paper shows that less crystalloid is the best. In our trauma center today, we currently own in a patient who is in profound hemorrhagic shock that gets liters and liters of blood products, only gets 2 liters of crystalloid in 24 hours. 2 liters in 24 hours. Increasing crystalloid is associated with death and morbidity in our trauma patients. Putting all this data together, in 2014, the Joint Trauma System and Tactical Combat Casualty Care recommended whole blood as the primary resuscitation fluid for pre-hospital resuscitation. This is 2014 in this DoD Department of Defense guidance. Jeremy Cannon published in 2017 a very similar paper for the civilian world from the Eastern Association of the Surgery Trauma Clinical Practice Guidelines. The recommended resuscitation fluids from that 2014 paper in previous versions did have colloids and crystalloids. They are no longer recommended at all. They're removed from the paper. And again, the primary resuscitation fluid recommended by the Tactical Combat Casualty Care is whole blood. All of the clinical practice guidelines from the Joint Trauma System, which is the Center of Excellence for Trauma Care in the United States Department of Defense, recommend whole blood or balanced resuscitation. Now back to data. Stacy Shackelford, Colonel Shackelford published in JAMA a couple of years ago now that you must give, to have optimal outcomes on the battlefield, Blood products must be given early, within 30 minutes of injury, and must be given in a balanced fashion. Doing so dramatically improves the outcome of the patients and decreases morbidity and mortality. But it's important that the blood products, these are combat casualties, had blood given pre-hospital to achieve these outcomes. In the civilian world, Jason Sperry published a prospective randomized study in the New England Journal of Medicine. So now we have JAMA and New England Journal talking about pre-hospital blood products and show dramatically improved outcomes as well in civilian trauma patients, multi-center, large number of patients. So let's talk about timing for just a second. Shackelford's paper talked about within 30 minutes. Jason Sperry's paper was pre-hospital, and both show significant outcome differences. You know, in the civilian world, it takes 128 minutes from injury till when operatively in the operating room before we have truncal hemorrhage control. 55 minutes if we did this control in resuscitation emergency department, and 28 minutes if we do this pre-hospital. These are civilian data now. And what we know is that there is this consistent curve of death. The longer you wait after injury, the more patients die. And so if we're going to really make a big difference in a data-driven fashion for our trauma patients, both civilian and military, but especially the military right now, we need to have these interventions pre-hospital in the hands of medics, in the hands of the doctors and nurses who work in the pre-hospital world. And for this discussion needs to be blood products. You know, there's this phrase that every minute counts. And so what we've done in the last couple of years is try to measure this and put data next to this phrase. When looking at this question in the in-hospital data from the proper study, every 1 minute delay from the time of in-hospital arrival to the time for calling for blood products was associated with an increased risk of death by 5%. So every minute delay increased death by 5%. The folks just recently published in the Journal of Trauma a summer study looking at pre-hospital intervention. Every 1 minute delay was associated with a 2% increase in the odds of 30-day mortality. So lacking of pre-hospital resuscitation with blood products increased death significantly, both pre-hospital and in the hospital. And then probably the best study right now was just published by Hazelton in the Annals of Surgery, 14-center prospective observation study of over 2,000 patients who received whole blood or component therapy. Whole blood was significantly better and associated with a large improvement in survival versus blood components of red cells, plasma, and platelets. So the whole blood patients did dramatically better. Now, policy is important. You know, we as clinicians can do some things we want to, but we need to have headquarters and the policymakers agreeing. And so these are U.S. data by policy makers talking about blood practices, blood products that are delivered to the battlefield by the Armed Services Blood Program. And at the beginning of the war, none of these were done. By the end of the war, low titer whole blood, cold store platelets, liquid plasma, freeze-dried plasma, and the walking blood bank were officially part of the Department of Defense policy. This is from now headquarters policy, Joint Trauma System, the Defense Committee on Trauma, and the Armed Services Blood Program. Low titer O whole blood is the resuscitation product of choice for the treatment of hemorrhagic shock for all casualties at all roles of care, pre-hospital and hospital. Low titer O whole blood, not type specific. And we'll talk about that in just a minute. And this is not just in the U.S., but our UK colleagues, Karen Brophy and his partners have also just completed a pre-hospital study of plasma and red cell transfusion on helicopters, on the ground, ambulances, and was associated with improved outcome as well. Now, how much? This is data that are just being published this month from the Armed Services Blood Program and from the Joint Trauma System. If we look at this data, it goes back to World War II and Korea and the war just completed in Iraq and Afghanistan. Okay. Patients who are transfused, how much blood do they need? And the patients who are transfused in CENTCOM, because we move lots of products pre-hospital, you need to plan on having about 7 to 13 units, or around 10 units as a median. 10 units is a median of whole blood for every patient that receives blood. Now, for all patients, all casualties, you can count from a planning factor of 1 unit of whole blood for every casualty. The percent of casualties who receive blood, very similar across World War II, Korea, and the Iraq and Afghanistan war, at about 20%. These are pretty important data from a planning point of view. It allows you to plan on how much blood you need, which obviously relates to supplies, training, and personnel. Okay, how do you do a pre-hospital blood product program? This paper by Mark Yazer, published in Pre-Hospital Emergency Medicine 2 years ago now, is how to do it. It goes through the logistics of and all the steps you need to do to safely transfuse pre-hospital blood. And it really makes the point that if we believe the data about blood product transfusion, and it is difficult to do plasma, platelets, and red cells pre-hospital, and platelets are extraordinarily important, that it is much easier just to do whole blood rather than try to do all 3 components. Now, we published this paper 3 years ago now. During COVID in the United States and around the world, blood products became in very short supply. The walking blood bank, or drawing blood from the soldiers or the civilians who are around, is a very standard practice in the military. It is not standard practice in the civilian world in the United States. We wrote this paper bringing together the lessons learned in the military on how to do a walking blood bank. It kind of goes through all the different steps you need to do, and we all know this. It's much better to have a plan in place ahead of time than try to make it up at 2 o'clock in the morning. So this is how to do a walking blood bank program. As we start to close here, walking blood banks and whole blood can cause people some unhappiness, and because tradition is the hardest thing to change. But if we do this in a data-driven fashion, talking about the outcomes of our patients, change can happen very quickly. I want to reiterate for a minute that type O whole blood is the best resuscitation fluid, not type-specific. In emergency situations, type-specific blood can cause major problems, whereas type O whole blood is a universal donor for males and females of all ages. And it is actually type-specific for up to 40% of patients, because type O blood is 40% of the population. This is upsetting to the status quo, but it's the only way that progress will be made. And I took this picture traveling on one of the highways in central Ukraine last year. I think I just want to thank you all for the opportunity to present today. I'm happy to answer any questions, and I have the greatest respect for what you all are doing as you defend your country from the Russian terrorists. Thank you very much.
Якщо можливо, в когось є питання до нашого американського гостя, ми можемо зараз їх задати в текстовому варіанті, бо він нас не чує. Так. Можна просто голосно, можна підійти. Ні, він просто нас не чує, справа в тому, що ми йому пишемо все одно. Але всім голосно, щоб ми всі чули його.
Питання полягає в наступному, тобто дуже крута інформація, по-перше, зібрана, дуже круті дослідження. Питання полягає в тому, можливо, наш спікер може поділитись досвідом саме донесення цієї інформації до широких мас солдатів і саме примінення цієї інформації на полі бою, тому що весь сенс дослідження всього такого, це по ітогу примінялося десь на полі бою. І було б круто почути досвід, людина неймовірно лежить якісь досвіди за спиною, почути досвід того, як саме приміняються ці дані, як вони доносяться до солдат саме ось на рівні поля бою.
Yeah, I think this question is about training. It is my experience working with military and civilian medics that anybody can be trained to deliver blood products. done, but it's actually relatively simple. Answering this other question about timing and proximity, I find these variables, just because something is close doesn't mean that the casualty can get there quickly. There is no data-driven time period within which it's safe to not give blood products. So for the military casualty, in the tactical situations, instituting blood products as soon as possible after injury is life-saving. I would not put a time period where it's okay not to give blood products. The goal of this is to make transfusion of blood products pre-hospital routine and simple, and not unusual. And if we train enough